Charlene, today what we're going to be doing is I'm going to have a look at your teeth, but in addition, we're going to actually be checking the soft tissues of your mouth. We're going to be looking with something called the Velscope, and it's
This video provides an outline of how to conduct a Velscope VX examination, from initial patient greeting through the entire process. It will illustrate potential mucosal variations and confounders that may appear in a Velscope VX exam, and provide you with a reference on how to proceed with these types of indications. Overall, the video aims to help develop your confidence in effectively integrating the Velscope VX technology as part of your patient assessment process. The Velscope VX Enhanced Oral Assessment System is a valuable additional component of a state-of-the-art comprehensive oral mucosal examination. The Velscope VX is intended to be used in combination with the traditional intra- and extraoral head and neck physical examination using standard incandescent light and palpation. Velscope VX does not replace or diminish the importance of the traditional head and neck exam. Rather, it serves to complement and strengthen the traditional protocol. The occasional patient may show initial reluctance to the Velscope VX exam, especially if they have at-risk habits. It's important to introduce the procedure in a way that puts patients at ease. Tell your patients that relatively few advances have been made to significantly enhance the visualization of the soft tissues of the oral cavity. Velscope VX is an excellent new technology that has been adopted as part of your office's enhanced patient care. The Velscope helps you assess the health of their oral tissues and can aid in the early discovery of tissue abnormalities, including cancer and precancerous lesions. Besides oral cancer, there are many types of conditions that occur in the oral cavity that can indicate problems with oral and systemic health. The Velscope VX exam is now established as a regular part of your office's initial assessment and periodic recall protocol. Remind your patients that discovering oral disease early can improve oral health, lead to less invasive, more effective treatment, and improved outcomes. Reduce preventable medical expenses for extensive surgery and post-op care. In some cases, even save a life. The Velscope VX procedure may or may not be covered by the patient's insurance plan. However, for minimal cost, a Velscope VX exam as a component of the traditional head and neck exam will provide valuable insight into the state of their oral health. Here are a few facts about oral cancer you may wish to convey to patients when introducing the Velscope VX. About 25% of oral cancers occur in people who do not fit the profile of high risk. These people have no history of excess tobacco or alcohol use and are not immunocompromised. Although the risk of oral cancer increases with age, an increasing number of patients under the age of 40 are being diagnosed with the disease. On average, somebody in North America dies of oral cancer every hour of every day. Conduct a thorough extraoral and intraoral examination, both visually and manually, palpating all of the structures of the head, neck, and intraoral mucosal surfaces. Ensure that the patient is wearing the safety glasses provided with the system. You are now ready to repeat the intraoral examination, this time using Velscope VX. Begin by covering the Velscope VX handpiece with a Velsheath VX. The Velsheath VX is a single-use, disposable plastic barrier used to enhance asepsis and minimize the risk of patient-to-patient cross-contamination. The Velsheath VX has been designed specifically for the Velscope VX handpiece, with cutouts on the top to help ensure that the clinician and patient side optics and the air grills are not covered. Next, attach a Velcap VX. The Velcap VX is a protective, single-use, disposable lens cover. Velcaps must be changed between patients to ensure asepsis, to prevent cross-contamination, to minimize fogging, and to protect the Velscope VX's sophisticated optics. Hold the Velcap VX by the rim. Position it parallel to the front face of the unit and gently engage the paper tabs into the groove on the outside of the handpiece. Make sure that the Velcap VX window is parallel to the face of the unit. Do not apply excessive force and avoid touching the clear plastic window. Before you begin, minimize ambient light to the extent you are able. Turn off the dental operating light. It's a good idea, if possible, to turn off operatory lights, lower blinds, and face the patient away from direct sources of light, such as windows. The Velscope VX handpiece emits a cone of blue light from the ring of blue LEDs situated around the front face of the unit. Position the VX handpiece approximately 3 to 4 inches from the tissue of interest. At distances of approximately 3 inches or less, the beam pattern will create a dark central area. This dark spot results from non-uniform illumination and could be mistaken for a genuine loss of fluorescence. Avoid this by positioning the Velscope VX no closer than 3 inches from the target tissue. Loupes have a narrow field of view. If you use loupes, we recommend that you first survey the entire mouth using the Velscope VX without magnification to visualize the overall pattern of fluorescence. Loupes can then be used to provide a magnified view of a particular area of interest. When using loupes, hold the Velscope VX the same distance from the mouth as when viewing without magnification, and then find a comfortable distance from the end of the gray eyepiece that allows you to achieve a focal point at the mucosa. Move your head, not the Velscope VX, for focus. During the examination process, full inspection of all mucosal surfaces is necessary and can sometimes be difficult to obtain. Use gauze squares to grip the lateral border of the tongue with one hand and extend the tongue to the opposite side by pulling it laterally toward the corner of the mouth on the opposite side. Or, have the patient extend their tongue as far as possible to the opposite side while using a dental mirror, retractor, or tongue blade to retract the cheek. A similar process is necessary for assessing the entire buccal mucosa by using a dental mirror or other instrument as a retractor, thus allowing direct illumination of the tissue with the Velscope VX. Retraction of the lips to allow full observation of the mucosa of the inner surface of the lip and labial fold can be difficult and may require use of a retractor or mirror. Visual assessment of the oropharynx and soft palate may require use of a dental mirror or tongue blade to retract the tongue during speech or when the patient is asked to say ah, ah, ah. The need to retract all of the appropriate tissues is the same whether using white light or the Velscope VX. When using the Velscope VX, however, one hand is occupied, holding and maneuvering the scope, while the other hand retracts tissue. In difficult circumstances, it may be necessary for the dental assistant or even the patient to assist the examining dentist. There is no clinical fluorescence presentation through the Velscope VX that is definitely positive for dysplasia, oral cancer, inflammatory oral changes, or any other type of oral disease. It's important to understand that the Velscope VX is not a diagnostic test with a positive, negative, or yes-no answer. Similarly, the conventional intraoral exam does not yield a definitive diagnosis from only the visual appearance under white light. The white light exam and the Velscope VX exam are analogous procedures with comparable objectives: the discovery of potential abnormalities that may require further investigation. The power of the Velscope VX is its sensitivity to detect subtle mucosal changes that help clinicians detect abnormal areas that might have been overlooked during the conventional exam. The best way to categorize what you see through the Velscope VX is in terms of normal and abnormal patterns of fluorescence. Abnormal tissue typically appears as an irregular, dark area that stands out against the otherwise normal fluorescence pattern of surrounding healthy tissue. Sometimes, however, an area of normal tissue may exhibit a combination of bright and dark areas. Try to develop an appreciation for normal patterns of fluorescence by using the educational material provided with your system, combined with your own clinical experience and common sense. The contrast between normal and abnormal patterns of fluorescence, as well as an appreciation of the underlying physiological structures, will assist you in differentiating between healthy mucosa and areas of concern that may require further action. Now that we understand the concept of normal variation, let's take a look at oral tissue under white light and Velscope VX. This is a normal floor of mouth. Sometimes the area around the sublingual gland can be well vascularized and can lead to a loss of fluorescence that represents vascular variation and not pathological change. On the other hand, the floor of the mouth is a common site for development of oral dysplasia and oral cancer in patients with a history of excessive use of tobacco and alcohol. That area deserves careful visual and Velscope VX observation. Sometimes a normal oropharynx can host varying numbers of lymphoid aggregates, which, due to tissue structure, display a pronounced loss of fluorescence that does not signal serious pathology. On the other hand, a patient with a history of risk factors such as tobacco, alcohol, STDs, or immune system suppression is at higher risk of malignant disease of the aerodigestive tract, including the oropharynx. The presence of an irregular zone of loss of fluorescence should never be ignored. Pigmented tissue, such as this example of an amalgam tattoo, appears dark under both white light and Velscope VX. The buccal mucosa is a common site for irritation and consequent inflammation. Inflammation always shows a distinct loss of fluorescence because of increased blood content. The intense inflammation associated with erosive lichen planus results in a pronounced loss of fluorescence. Note the hyperkeratotic area on the ridge. If this lesion showed increased fluorescence, it would most likely be a simple case of uninflamed hyperkeratosis. In this example, however, the area shows a strong loss of fluorescence and is, in fact, dysplasia. If a suspicious area is discovered, re-evaluate under white light and Velscope VX, trying to identify what might have caused the region to appear abnormal. Take into consideration its appearance under both Velscope VX and white light, its response to palpation, as well as patient history information, including risk factors. Document all findings, both normal and abnormal, in the patient's clinical record. The Velscope VX oral lesion form, tracking chart, and other useful documents are available online at velscope.com. Re-examine any suspicious regions under white light as follows. Re-evaluate the region under white light. Re-palpate the region. Identify any conditions that may have caused the region to appear dark under Velscope VX examination. Some conditions that may appear dark under Velscope include traumatic lesions such as chronic irritation from denture friction or cheek biting, pigmented lesions such as melanotic macule, common infections such as oral candidiasis and recurrent herpes, and inflammatory conditions such as aphthous ulcers, or vascular lesions such as varicosities, hematoma, or petechiae secondary to trauma. If after re-examination the cause of the lesion cannot be identified, observe the suspicious tissue through the Velscope handpiece while applying diascopic pressure. This is often referred to as blanching. Compress the lesion using a light amount of pressure in a sweeping motion with the back side of an explorer, dental mirror, flat instrument, or your finger. Fluorescence is typically lost in areas of inflammation. If fluorescence returns when you compress the tissue, there may be an inflammatory component to the lesion. It's important to note, however, that dysplasia can also be accompanied by inflammation. If a lesion does not completely blanch when compressed, heightened observation and follow-up is warranted. For a comprehensive discussion of tissue under diascopic pressure, please refer to the training materials provided with your system. If a suspicious area cannot be ruled out as a normal variant or otherwise benign, a follow-up visit for re-evaluation should be scheduled in approximately 2 weeks. The dentist should remove all potential etiological contributors in the area, such as trauma or infection. The intervention could be as simple as relieving a pressure point under a denture base, recontouring a sharp cusp, or treating for oral candidiasis. If the lesion has not resolved after the follow-up time, proceed with further investigation of the suspicious tissue according to your regular protocol, which may include biopsy or referral to a specialist. Your clinical judgment will ultimately determine the appropriate course of action. Persistent abnormal findings should never be ignored, and should be followed until they either resolve or their cause is well understood. Emphasize to the patient, however, that persistent abnormal findings do not necessarily indicate cancer. If the patient cannot make a follow-up appointment, or if the dentist feels that the patient is unreliable, immediate steps are advised, including immediate biopsy if possible, or referral to their primary care provider or a specialist. Remember, the gold standard for diagnosing precancerous and cancerous lesions in the soft tissues of the oral cavity is surgical biopsy. A biopsy that returns a result of dysplasia or any other pathology is a valuable finding, not a false positive. Discovering dysplasia early allows for the highest probability of a favorable treatment outcome. Dysplastic lesions, depending on the grade, have an increasing risk of progressing to cancer. Discovering them early allows for the highest probability of a favorable treatment outcome. Opinions differ on the treatment options for the various degrees of dysplasia, but it is generally accepted that detection is critical, as is regular follow-up. The role of the general dentist is to detect tissue variations, abnormalities, and frank pathology, and to establish the best diagnosis possible within the diagnostic processes they are using. The role of the RDH is to assist the dentist in that process by detecting suspicious tissue changes. The dentist-hygienist team can then decide next steps that may include a follow-up visit, a biopsy, or specialist referral as appropriate. Abnormal mucosa can be caused by a wide spectrum of conditions. Just the same, it is much better to err on the side of caution and sample suspect tissue than to ignore a potential disease process that could lead to oral cancer or another serious condition. A significant advantage of the Velscope VX screening system is easy photo documentation with a variety of camera types. No special filters are necessary, and the Velscope VX digital camera, which is sold separately, is easy to use by all staff members. It's recommended that all areas of concern be photo-documented, both under standard lighting conditions and through the Velscope VX handpiece. The Velscope VX digital camera is an ideal tool for documenting the fluorescence response of the tissue under blue light excitation, as well as its appearance under normal lighting. It's recommended to acquire both fluorescence photographs and conventional photographs using the camera's built-in flash when photo-documenting an area of interest. The discovery of precancer or cancer is one of the most profound results of the Velscope VX exam, but it's important to remember that many oral lesions are more readily visualized through natural tissue fluorescence. A study at the University of Washington demonstrated that the addition of Velscope VX to routine clinical examinations resulted in the detection of mucosal abnormalities that were not detected by the conventional white light exam. Importantly, these abnormalities included not only dysplasia, but lichen planus and other inflammatory lesions. The study highlights an aspect of Velscope VX that is sometimes overlooked. In addition to the detection of dysplasia and cancer, the Velscope system is a valuable tool for the discovery of conditions that may not present with obvious oral change when viewed under white light, either because the condition is in its early stages or because the nature of the lesion masks the underlying inflammatory change. These conditions may include viral, fungal, and bacterial infections, inflammation from a variety of causes, including lichen planus and other lichenoid reactions, traumatic lesions and localized areas of trauma, squamous papillomas, and salivary gland tumors. It bears repeating that the Velscope VX is not a diagnostic test and does not, consequently, incur false positives. It is one component of the oral mucosal assessment process, and the final decision about whether disease or abnormality is present depends on the sum total assessment from data collected from patient history, palpation assessment, white light examination, and Velscope VX assessment. Understanding the potential of the Velscope VX system adds significant clinical value to your practice, since the appropriate treatment of mucosal abnormalities, including cancer and precancer, can enhance care, add to the prestige of your practice, improve your patients' quality of life, or even save them from a potentially deadly disease.
Thanks a lot for coming in today, and we'll see you in a couple weeks, okay?